away from it. You might get a twitch in the end, but you don't want to go there. So you need to be on the edge of the transverse process to get this twitch. Okay. So if you have to walk off too much, take out the needle and do it. I think this video started a bit early. So I'm going to show the video. This is a video of the lumbar plexus. This is one of my fellows in regional anesthesia doing this block. This is an old video which is there on the group. I think this was posted somewhere in 2012. So you can see the landmarks are drawn. You can see that it's actually 1/3, 2/3, a centimeter below. Okay, he's going to try to hit the transverse process. And as he hits the transverse process and walk off it. Okay. And this is a 10 centimeter needle. And this is not a very big patient. Okay. And you can see that it's almost there. The whole of the needle is there. And when you actually get to it, you'll see the twitch. Can you see the cordyceps response? This is what you're looking for. You're looking for the cordyceps response. When you do that, then you start coming down. And can you see the syringe, where the syringe is? Okay, I'll come to it later on. Okay. So this is a lumbar plexus block. When we actually started off the group in 2012, there were very few people doing it. But after seeing that and after discussing the safe way of doing it, there are a lot of people who are now doing lumbar plexus block regularly. So moving to the sacral plexus, so like I said, sciatic nerve gets the components from L4, L5, which are part of the lumbar plexus. You got posterior nerve of thigh, which comes from S1, S2, S3. We got the superior gluteal nerves, inferior gluteal nerves. They are important when you're doing a parasacral approach. Pudendal nerve, we hardly block. Okay, posterior nerve is missed out when you're actually blocking the nerve lower down, that is in the subgluteal region. So this is what Dr. Farke was talking about, the Mansur's approach. In Mansur's approach, it is you mark the line between posterior spheric spine and your radial tuberosity. On this line, you go by 6 centimeters. I don't know what is your 6 centimeters or my 6 centimeters is there. It's a posterior spheric spine. Heithal was asking, how do you feel it, sir? How do you feel it? How many times do you feel it? So what I might be thinking of posterior spine may not be. So you mark it and then you go 6 centimeters and I say, well, I'm not getting any response. I would go for popliteal fossa, Moller's approach, or subgluteal approach. Okay. So we said, no, this is not. Look at, so we'll look at it more closely and see if there is a better approach to it. Because again, 6 centimeters, you can't have anything at a fixed length. You can't just say that, okay, I will actually put that 6 cm. So what we did is we actually looked at some of the studies and we saw that the junction of cranial 1/3 and 2/3, that point is a good point. And that is, can be used for any patient. We don't actually have to measure 6 centimeters. We just draw a line between the posterior spine and the greater trochanter. That's if you can feel it. And then divide into cranial 1/3 and caudal 2/3. Go at that point and you get a good response. So this is the parasacral approach. And there you can see that I've marked out the posterior spine, marked out the ischial tuberosity, divided into 1/3, 2/3. And we're going to go at this junction. Now we also know that the nerve passes between the greater trochanter and ischial tuberosity. So sometimes if you don't get the response when you're going almost perpendicular, you can actually start angling the needle towards that. That's what Maulik was saying. You need to have a bit of imagination. You have to open your X-ray eyes, your ultrasonic eyes, and think how the nerve will be passing through. Okay. Sometimes our landmarks are not perfect. We may not see that, but okay, there you go. Okay. So you get response exactly like you would do when you actually do a sciatic nerve block, whether it is a subgluteal or a Raj approach or popliteal fossa. The response is always the same. Okay. But one of the things you will notice that when you are actually doing a parasacral approach, you can sometimes see the gluteal twitches. Okay, you're blocking the superior or you're actually stimulating the gluteal nerves, and you know you're in the right place. You're actually in the right direction. You need to go deeper. You go in deeper, and you will get this response. So what can go wrong? Perfect blocks. What can go wrong with these blocks? In UK, they are shit scared of this block. If you are actually, there is something called doctors.net. I actually just left the group because every time I actually talked about lumbar plexus, sacral plexus block for hips, they would get very twitchy. It's a dangerous block. I said, I've done thousands of them. So what are they worried about? What worries people about lumbar and sacral plexus blocks? More to do with lumbar plexus. I told you. Okay, total spinal, because there are cases where they did not actually recognize it. He got a beautiful twitch, the legs were kicking away. And they injected because of a fantastic response. They aspirated, injected, aspirated, injected. They were aspirating CSF and injecting into the CSF, still not realizing what it is. They were doing a very nice spinal anesthesia. So they did a total spinal, okay. But they did not recognize the patient when the patient stopped breathing, because we do a lot of blocks, but rather most of our blocks are done asleep. Okay, when the patient stopped breathing, okay, then patient went into a rest because you had a total spinal. Patient went bradycardic and things. You actually injected 20 mL of 0.5%. That's huge amount, isn't it? 5 milligrams into 20. Okay, that's a huge dose. Then what else can go wrong? Epidural spread can happen, okay? Not that as bad as injecting 20 ml to CSF. But you can get good analgesia, so you won't be worried. Intraparietal hematoma is rare because if you see it, it's actually more. You're actually outside your psoas muscle. You're not beyond the psoas muscle. It can happen if you're taking 15-20 centimeters. You get a spear. Okay, if you're thinking of kebabbing the kidneys and things like that. Other is vascular. There are vascular structure. There are blood vessels there. Okay, intravascular injection. So, one day, people are worried about total spinal. People are worried about intravascular injection, large volumes. Okay, you inject. Small vessels are there. You may not be able to see them. You may not be able to see blood coming out. Okay. So how do you prevent these complications? How have we prevented in thousands of cases? One simple solution. Like I said, you aspirate in spinal, nothing comes out, it is same as water. So you're aspirating and happily injecting into CSF. Blood vessel, you try to aspirate, it's small, it collapses because you're creating negative pressure. It doesn't. So one simple solution.
Gravity, disconnection.
Absolutely. You see that this syringe was away. Okay, do not connect anything to the extension tubing. That's it, a simple solution. Okay, of the thousands of cases, we've had 3 cases reported till now where we saw CSF coming. So fine, so what? Take the needle out. Look at your landmarks because you're too medial. That means you got CSF, you're too medial. Because skin moves, sometimes you feel the skin moves over the spine, you get it wrong. Okay, so nothing, no worries, take it out. Okay, do it again. You're not causing any harm at all. Because you go into dural cuff, so that's. Blood we see maybe 1 or 2 every year in hundreds of cases we see. And this is the reason one of my colleagues, one of the registrars who was training with us, he said, I'm going to do trauma list. That's going to be one of my job plans. I want to learn lumbar and sacral plexus block. So he said, fine, come and join. So he came with us. He stayed in my theater for a few days. And I learned lumbar plexus and sacral plexus block. And we taught him just one thing. He said, you do whatever you want. Just don't attach your syringe to your extension tubing. And you won't believe it. The week after, he came running to my theater when I was there. You know, sir, you saved my life. He's a Russian. You saved my life. So what happened? He said, you know what? I saw the CSF coming. I said, okay. Yeah, I hope you didn't inject the local anesthetic. He said, no, I didn't. Okay, fine. So that is the safety of that, and that's what we have taught. Okay, just one thing. Do not attach this. Here, unlike in ultrasound, where if you inject local anesthetic, okay, things can go wrong here. Okay, sorry, the air goes in, everything goes haywire. Air is no good for ultrasound. Here it's not. Okay, aspirate and inject. Even after you have seen that, even though you know that there's no CSF, no blood, always have aspirate inject. Thank you very much, guys. Thank you for listening. Any questions?
Regarding palpating this posterior superior gap spine, this is the technical gave sacral plexus in obese patient.
Yeah.
Solution we did it with IITV guidance. We locate the posterior superior gap spine and then we gave the block and it was successful.
Yeah.
So we can use IITV because we are doing it in orthopedic.
Yeah, you can. If you're doing the orthopedic work or you got ultrasound, you can see it on the ultrasound as well. Yeah. Hey, Louis, who's next? It's your turn. Sorry, I forgot.